Hello.
Okay. Just to make
Yes,
sure.
Shintaro.
Okay. Thank you.
Yeah.
Have you started the YouTube?
Yeah, the meeting is live now and we are recording it as well.
And but it's not live on YouTube.
Okay.
Can you check the YouTube?
Yeah, I'll just check. Give me a second, please.
Okay.
Yeah, I can see that. We are live. We are live.
I cannot check.
You will have to subscribe or you need to go to the channel. We have provided a channel link.
Yes.
To people in the brochure. You need to click on that link and then you'll be able to see the live. Actually, it's an instant live. We did not schedule a live meeting.
It's not running. Dr.
Hello.
Datta, it's not running in your channel.
I guess we all got the notification. I'll have to see it again. It's live. It's live. It's live.
Can you show me sharing your screen? Because
just a second. Just a second.
I can see it on YouTube.
Okay.
It's yeah. There's a small lag, but it's definitely visible.
Okay. Now I see it. Thank you. Thank you very much. I see it. Thank you.
Yeah. Okay. Okay.
Sorry for the delay.
Good afternoon, esteemed colleagues and dear friends. It is an honor to have you all in this virtual session on network and technology in dental education and practice under the aegis of APAN, Asia Pacific Advanced Network, and TEMDEC. Without taking much of your time, I call on Professor Dr. Zakir Hussain, Principal, University Dental College, Dhaka, and Head of Department Orthodontics, to present the welcome address. Over to you, sir.
Hello, everybody. Thank you, especially Dr. Deborah, for inviting me to say something. First of all, I would like to say that I'm very much pleased to join with you with all young researchers that will run the Asia Pacific network. I think participants from India, Nepal, and Bangladesh are joining here, and they will work this session how to improve research and education in this area. And I hope this session will be a successful one, and all participants will have their own views so that research and education can be promoted or improved in this area. And wish you all the best for success of this session. And we have a good friendship, good teamwork from this meeting, and wish you all the best. Thank you very much for inviting me to join today. Thank you. Thank you.
Thank you, sir. Thank you so much. Now, the first part of this session is dedicated to teledentistry for patient care. Our first speaker is Dr. Arpita Rai. She is an associate professor of oral medicine and radiology at Rajendra Institute of Medical Sciences, Ranchi, and is a director of telemedicine services at the medical hospital there. She's a dear friend, and today she will share with us the extensive telemedicine and telementoring work that's being carried out at their institute. Dr. Arpita, I welcome you, and I hand over the stage to you now.
Thank you so much, Dr. Deborah. And first of all, I thank the organizers, APAN 53, and Dr. Deborah, my very beloved friend and companion and guide, for giving me this opportunity to share with you all this presentation that I have made for what all we are doing here at RIMS Ranchi. So without further ado, I'll share the slides with you all and start my presentation. Is the screen visible? Slides visible?
Yes, yes, Dr. Arpita.
No, you stop sharing.
Yes.
I stopped sharing. Okay.
Please start sharing again.
Okay.
And please put it into slideshow.
Just give me a sec. Is it all right
Okay.
now?
Yes, it's visible.
Yeah, so we are here to discuss this topic about telemedicine and telementoring, where technology meets health. So a warm welcome from India. And this Multimedia Resource Center at Ranchi, this was established in the year 2020, originating from the need of COVID-19. In the first wave, since we did not have any such facility for telemedicine at this institute, so a committee and a center was formulated, and I was given the charge of the center. And this EOPD was inaugurated on 18th April 2020, and we started giving services from 20th April 2020. And the mandate of this center is to start EOPD services. It was told to us to start within 5 days of establishment of this center. Secondly, creating a digital interface between specialist or super specialist of this tertiary care center. RIMS Ranchi is a tertiary care center of Jharkhand, and with doctors serving in the primary and secondary care under National Health Mission of this state. Then thirdly, to organize online training programs, webinars, panel discussions, etc., and to provide health education and awareness programs. So our major agenda and objective was to start the EOPD or telemedicine services. For this, because in the first wave of COVID-19, the OPD services were so much hit, and we have about approximately 3,000 patients OPD per day at RIMS in normal days such as now. So shutting down the whole OPD, we had to, because of that, we had to come up with an alternative. And for that, we started two things. One was our telephonic EOPD, and other is the eSanjeevani EOPD. So eSanjeevani EOPD over time, it is divided now into two parts, wherein in one sector, we have a direct interaction of the doctor with the patient. Whereas in the second, we have a doctor-to-doctor consultation, wherein specialist cases are referred from primary and secondary healthcare medical officers and dental officers to hubs like RIMS Ranchi and AIIMS Devghar. So the first is our telephonic EOPD, because the eSanjeevani portal was yet to be launched in the state. So we initially started with this EOPD on telephone. So we generated one toll-free number and 3 numbers, which we publicized in media and on our website, and with such advertisements all over the city as well as in the RIMS. And then the patients usually call us on these numbers. In time, we had this notification also given out from the Honorable Secretary for Medical Education and Health, wherein it says that all prescriptions generated through eOPD of RIMS have to be given free of cost to the patient from the government hospitals, like close by CHC or a PHC or any other kind of a government hospital. They will honor the prescriptions given out from eOPD by RIMS. So this is how we do it. So we have 4 interns posted who are attending all the 4 phones in the specified time, that is 10 to 1. And this is our intake form based on the telemedicine guidelines that have been released in the country. They were released in March 2020. And they take the form and sign, they take the complaint, and accordingly they write the referral department. Then in the after one, we sort out these forms, like in every day we get about 70 to 90 calls, and then we sort these according to departments. And in the second shift from 2, doctors from different departments would come and they would call back the patients on the numbers that were taken in the input form, then ask the full details and write the prescription along with the signature and stamp. So this prescription, what they are writing, is to be honored by any government facility free of cost to the patient. So that is the arrangement we had. This form we used to send the patient through WhatsApp only. So this was our telephonic eOPD for those people who are not able to have internet facilities and are not savvy enough to do audiovisual consultation. So at least they would call someone. And if they do not have a WhatsApp number, in those cases, we would ask them to give a number of their relative or anybody close by. Or in worst come cases, we would give the prescription to the pharmacist directly. So that is how we used to cater to the major population who does not have internet facility. This is how we publicize the eOPD in several newspapers, and about 60 to 70, or on some good days 90 patients or 100 patients would also call. This is the data for eOPD in 2020, 1412 new consultations. We followed up 165 patients because they required a second consultation, and total being 1577. And in 21, it was about 652. Total cases is 2,229 using only the telephone, wherein there was no audio visual contact with the patient. We were using telephones, and patients, if required, the doctor would ask for previous prescription on WhatsApp, and a WhatsApp call was only made to the patient if required. Then we have the second arm, which is eSanjeevani OPD. This is a flagship program by Government of India. So it's a stay-home OPD, which is developed by Center for Development of Advanced Computing, CDAC Mohali. And basically, it is a citizen-friendly, web-based national teleconsultation service. And the government actually had come up with this for doctor-to-doctor consultation, but keeping in mind the COVID situation which arose in 2020, this was converted into a patient-to-doctor interface. So here there is facilities for patient registration, token generation, queue management, audiovisual consultation, e-prescription, SMS and email notifications, and free service. This is totally configurable. And as you can see, the eOPD of Jharkhand, such kind of advertisements were given in papers, websites from all health departments and all related websites. And basically what we do here is that there are medical officers from RIMS as well as the state government who provide general consultations on Monday to Saturday between 11 to 1 and 3 to 5. Along with this, we have psychiatry OPD every day, Monday to Saturday from 1 to 2, as can be seen here. And then RIMS provides specialist OPD for general medicine, for example, on Mondays between 2 to 3. So all specialist OPDs are there between 2 to 3 for different departments like general medicine, orthopediatric, surgery, gynae, etc. Even dental OPD is on Friday along with ENT OPD. So this is the eSanjeevani OPD.in. This is where patient can directly call. So this is how the dashboard of eSanjeevani OPD looks like. The patient has to go here and do patient registration by clicking the link here. And then patient will be able to log in. This is the data from eSanjeevani OPD, wherein about 2,96,858 hours of teleconsultation has been done. And at the time of making this PowerPoint about 2 days back, 172 doctors were consulting at the moment. Usually it takes around 2 minutes, 29 seconds for a consultation, and the wait period for patient is 6 minutes. So what does a patient do? A patient usually goes on eSanjeevaniOPD.in, then they register and take a token. A message will come. They will have to wait for the message notification, and then accordingly, using the patient ID, they will log in. Then they wait in the waiting room. Once their number is there in the queue, so a call now button will start reflecting, and a ring-like thing will come on the portal. So they have to click call now button, and then they can do audiovisual consultation with the doctor. So this is how the portal looks like once they have entered, the patients have entered. So there they can see how many doctors are online. Their all past records will be here. Patient has facility to upload all records for the first time, and they will be stored and recorded here forever. So past records, past consultation, past prescriptions can be downloaded from here. From here, the patient logs out. This is patient ID and details, as we can see. So this is the waiting room. If there are multiple patients, we can see several figures like this here, and this is doctor available. So whether doctor is available or not. This is the dashboard from doctor's side. So once the doctors, suppose here one doctor has logged in, and then you can see so many patients are waiting over here, and then there is a consultation request. As soon as both the doctor and patient are available, consultation request will be sent using a ring kind of a thing on the device, and you can either accept or deny it. So once you accept it, you can see the patient's demographic details, the medical records can be, you can ask and write, and allergy details and all can be written. This is audiovisual portal, so patient and doctor can be visible. You can, if there is a problem with the internet, you can use chat option also. Sometimes from far-flung areas, we are not able to get the bandwidth, and therefore video is not very clearly seen. You can maximize the video for full screen in case for dermatological lesions or something like that. And then accordingly you fill the form, and this is how a prescription is generated. So patient's demographic details will be filled, patient's general information, history, the diagnosis, and the medicine you have prescribed, any advice you have given. This is the signature while doctor's registration that we get, and that will be displayed on all prescriptions along with the doctor's designation and all, along with their medical registration number is reflected here. So such prescriptions are honored by all medical government facilities and given free of cost. And then there is one more aspect of eSanjeevani, which is doctor-to-doctor consultation, which is started from the health and wellness services sector. So government has come up with this health and wellness centers under the Ayushman Yojana, focusing on such kind of objectives, and we know so many have been established in the country. So here, how it is related to eOPD is that patient in a rural area who does not know how to, go to eSanjeevaniOPD.in and register himself, or is not aware of telemedicine through telephone of RIMS. So that patient comes to the primary health center or a community health center or a health and wellness center. And from there, eSanjeevani consultations can happen with the district hospital doctors. And the cases which they feel are difficult enough to diagnose or treat, or they require a second opinion or something, then they refer to RIMS Ranchi Speciality Hub or AIMS Devghar Speciality Hub. So the whole, this is how it is a 3-step process from CHC, PHC and Health and Wellness Center to district hospital, then to the tertiary care center. This is how the dashboard looks like. And it is almost similar, developed by eSanjeevani, just that it is not opd.in, it is only .in. This is how the appearance of the after registration looks like. And here one doctor from a medical officer has logged in from one side, maybe from any districts. It is Ramgarh district here. And one doctor from RIMS side would log in from this side. And they can talk, and already cases, how many cases are received, and all information about the case is already entered by the medical officer from the state. So this is the data from Jharkhand state. So many 10,754 consultations under this eSanjeevani. This we do between 11 to 1 every day from RIMS Hub. We log in, our doctors log in according to roster. from 11 to 1. Whereas for patient to doctor, we log in between 2 to 3 p.m. And for general consultation the whole day. So this is the data from our doctor to doctor e-Sanjeevani OPD. There is one more advantage. All kinds of government policy regarding telemedicine and all, even regarding COVID, are all updated on these portals. So it is quite easy to keep yourself updated through this. So our first mandate of starting e-OPD services and second of connecting super specialty and specialist hub with the primary care. This is what we are doing in that aspect. I would end with our third and fourth mandate, wherein we do telementoring services by organizing some webinars. We have an international webinar series where some time back we had Dr. Gordon Gayat from McMaster University, Canada. And we have some online health and awareness programs. We have a medical education journal club. This is Dr. Qasem Hamdi from Gulf Medical University who had joined us on this. And there is a meta-analysis and systematic review series and research planning and reporting series. From my end, we are doing a tobacco cessation program, which is concurrently being held today, this time, and some hybrid webinars. This is one thing that we do here is a clinical grand round. We went online with clinical grand round during COVID and are continuing that for now. And these are the services that we are doing through Multimedia Resource Center. And thank you so much for giving me your time and attention.
Thank you so much, Dr. Arpita. It was an eye-opening presentation. Truly a lot can be achieved through telemedicine, and we thank you for bringing all this to light. There is so much to learn. We'll discuss with you shortly. We move on to the next presenter, Dr. Arifa Mahmood. She will present her research work on smartphone applications in teledentistry. Over to you, Arifa.
A very warm afternoon to everyone. I'll be discussing about the various smartphone applications that were reviewed towards an evidence-based teledentistry. Research in the health-seeking population and the discriminated proportion of the healthcare providers rings an alarm to open new pathways of healthcare delivery. Talking about the oral health, the access to the primary care does not fulfill the demands of the anticipated population in need. Insufficient dental resources, cost, time, travel, and the most recent fear of pandemic contributes to dental neglect among people. Where there is a will, there is a way. Teledentistry, like telemedicine, can open new horizons for the field of dentistry. As an aid to the same, smartphone applications have come to rescue. When properly studied as a part of literature, their functionality can be better understood along with various features, limitations, access, etc.
Sorry to interrupt. It seems as if you're not in slideshow.
Okay, sir, I'll start sharing again. Is it fine?
What is your situation right now? Okay, You are in edit mode, and it is fine to just give a presentation in edit mode. So please continue.
Sir, is it fine if I continue this way?
It's fine to just go with this screen right now.
Okay, sir. I'll stop sharing.
Dr. Arifa, please continue.
Sir, Dr. Shubham is sharing on my behalf.
Okay, visible.
Yes, sir. So a number of apps are available on the popular app stores such as the Google and Apple, which when properly rooted into the literature can provide a better understanding of their functionality, features, etc. that can be of great benefit to both the dentist as well as the patients. One such popular app is the dental monitoring app. One such popular app is the dental monitoring app that is available on both the app stores, that is the Google and the Apple. It is a tool for the monitoring the orthodontic tooth movement that helps the dentist to keep a track of the treatment follow-up of the orthodontic patients. Now, the app can be beneficial for both the dentist as well as the patient, as it reduces the unnecessary wastage of time and travel. Other apps that were reviewed in the literature include the Teledental, the Mimosa app. Unfortunately, these apps are no longer available for the consumer use. Another app that is available on the Play Store includes the Teledentics app. It is an online consultation app that is imbibed with the feature of video conferencing with the dentist. SmileMate is an app that uses the artificial intelligence system to assess the primary oral healthcare needs of the patients, so that the patient as well as the doctor gets a fair idea even before entering into the dental chair about the various treatment procedures that are to be carried out for the patient. Teledent is a pediatric dentist app that is used for scheduling appointments, keeping up of track of visits, and follow-up along with the treatment. Dentaloo is an app that is used for booking the dental appointments. This app is also helpful during the booking appointments of the emergency dental services. Straightly Direct is another app that unites the orthodontist as well as the teledentistry so as to deliver clear aligners to remote locations. Unfortunately, there is not much evidence-based literature on the topic. The fact that these apps are often made for study purposes, such that after their use, they are no longer available for the consumer use. As a part of conclusion, since the use of smartphones is increasing worldwide, this gives sunshine to the budding field of teledentistry. It is the need of the hour that such smartphone apps have to be reviewed cautiously and the patient's attitude towards them to be studied, such that they can help in developing new ways of delivering the dental care to the patients. Thank you.
Thank you, Dr. Arifa. We move on to Dr. Shubhangi, Dr. Shubhangi Premchandani. She will present to us a new application called Exodont for post-operative patient care. Dr. Shubhangi, over to you.
Thank you so much, Dr. Deborah. I'll just try to share my screen. Just give me a minute. I hope my screen is visible to all.
It's visible.
Yes.
Okay, hello, very good afternoon to all. I'm highly obliged to be here to present my paper. I will be presenting the paper on Exodont, which is an innovative app that we have developed for the post-operative care of patients following a dental extraction. Before talking about the app, I'd like to briefly talk about some of the common post-procedural complications that occur following a dental extraction. And we have chosen dental extraction as it is the most common minor oral surgical procedure. Some of the common complications include alveolar osteitis or dry socket, as we may know, and it being the most common and the most painful. The others include post-extraction hemorrhage, infection, trismus, paresthesia, to name a few. The most prevalent cause behind these complications is the lack of adherence to post-treatment instructions. And this is something which is preventable to a great extent if we can ensure proper adherence on the patient's part. And for that reason, we have come up with an app which is called Exodont. The methodology behind developing this app includes 4 steps. The first one being developing a post-operative treatment plan, wherein a team of oral surgeons as well as a few general dentists devised a list of post-procedural medications as well as instructions based on the previously available data. Then the team conveyed the technological requirements to the tech team, ensuring that the doctor is able to choose from the above mentioned list of medications and the patient gets the timely reminders for the same, also ensuring confidentiality of the patient records. The third, the app design was then determined, making sure that it is user-friendly both for the patient and the dentist, and with the backend server for storing and managing notifications being sent to the patient, and at the same time to be able to adapt to the different common operating systems. And finally, the field testing and validation was then done using the user version of the mobile application rating scale. Talking about the app, it is an Android-based hybrid app which can be accessed via a web page and typically has 3-level architecture. The first one being the user interface, which was designed both for the patient and the dentist. The second being the logical layer, which enables the user to communicate with the software, and the third, the database layer, which securely stores all the data, including the patient information. So this is how the application will appear on the patient's smartphone, where he will be able to view all his details along with the notifications that are being sent to him, and a feed section with oral health information can also be viewed by the patient. This is the admin panel, which will be accessed via a web page where the admin or the reception staff will be able to add a new patient, entering all the details. And as we can see here, the admin can view the list of all the patients in the view patient section and can then proceed with adding the course of medication. The patient medication course can then be selected from this page, which has a drop-down list of generic names of all the commonly prescribed medications, and the frequency, if we have to give it once, twice, or thrice a day, and the course, the duration of days that can be selected based on the surgeon's prescription. And this is how the list would appear, the list with the medications. Here we can see the dashboard showing the patient list and notifications that are being sent to the patient. Coming to the analysis of the app, which was done using the UMARS questionnaire, which was filled by 10 patients who had tried this app, according to which the perceived impact of the app received the greatest mean of 4.6, whereas the score for engagement had the lowest mean of 3.5, probably owing to the fact that the application does not, as of yet, has a provision for the user to input any data or feedback. Currently, there are more than 165,000 mobile health applications. Some common ones are clinical event annotator app, which is used for real-time patient monitoring, Mozify app, which helps us to report the dengue cases, See Me smoke-free app for smoking cessation. And in terms of dental applications, the earliest evidence reported was for teleassistance for minor orthodontic emergencies. Some other apps like Brush DJ encourages the user to brush his or her teeth for the recommended time of 2 minutes using music as a timer. Another serious public health menace that we wish to combat with this app is antibiotic resistance, which can occur due to improper completion of the antibiotic regimen, missed doses, or self-medication. And this app aims to promote judicious and timed use of antibiotics, thus preventing unscientific short courses, the forgetful missing of antibiotic doses, or self-prescribed antibiotic intake in patients. All right, so currently the app is being used only for the post-op care of oral surgery patients, but it can also be expanded to other fields of dentistry, including teledentistry, booking of appointments, and for post-op care in other fields, other specialties of the field. So to conclude, I would say that Exodont is a promising mobile health app specifically addressing post-operative treatment adherence and medication after tooth extraction. And the app has also shown improved patient compliance and increased medical adherence. So to summarize, I'll use this flow chart to explain as the patient arrives and undergoes the extraction, he will be required to visit the reception afterwards, and the reception staff will then enter all the patient details as well as the medication as per the surgeon's prescription via the admin panel, and then instruct the patient to download the app from the Play Store. The patient will then log in into the app using the username and password provided to him by the staff, and the patient will then start receiving timely notifications based on his prescription and time of extraction. So that brings us to the end of this presentation. Thank you so much for your patient listening.
Thank you so much, Dr. Shubhangi. That was really an interesting app to hear. We move on to the next. We're running a little short on time. We have Dr. Shubham Datta. He will be presenting to us about an innovative pedodontic app for pediatric patient care. Dr. Shubham.
Hello, am I audible? And is my screen visible?
Yes.
Okay. So very good afternoon. This is my presentation, which is basically a prototype model of an AI-based application for home-based pediatric dental care. Before, just a second. Okay, so I'm audible, right?
Yes.
Yeah. So before moving directly into the smartphone application, let us just look into a little bit of fact which is already available. This is a study which was done by Sadhana Kandaval, and this study shows various features offered by smartphone applications which are already there serving for dentistry. And if we look into the data, we find that there are features like individual calendar, schedule reminder, symptoms report, appointment notification, private messages. These features are offered already by the smartphone applications. And if we narrow ourselves down to smartphone applications for pediatric dentistry, we find that there are multiple applications which serve various purposes. For example, we have this Molar Propolis app and My Smile Buddy app, which serve the purpose of oral health education and promotion. We have My Little Dentist, which is serving ourselves for behavior guidance, and teledentistry during COVID-19 was done using your telephonic communications. So next, moving on to an interesting aspect of healthcare related technology, we see that that patients tend to Google their symptoms up, and then what they reach on to a diagnosis which is completely bizarre. This is technologically, or if we say that if we become a little bit tech geeky, then it is known as cyberchondria, and it is actually health anxiety in the internet era. And this is basically what I find I think I would be addressing in my app. So to understand cyberchondria, we'll have to look through a little bit of through some case scenarios. Beginning with the first case scenario, we have this kid. He finds his teeth yellow, and I guess his friends are teasing him. He Googles himself up, and he thinks that he finds that he'll have to go to the dentist. But what he does instead is he brushes his teeth and brushes his teeth vigorously and for a little bit more time. And what happens is that his tooth color does not improve. Rather than he thinks that he has lost a little bit of tooth structure. Next case scenario is that this kid fell down while he was outdoors, and he injured his tooth, and he again he feels that he'll get a bashing from his parents, and that is why what he does is he performs a Google search and regarding it, and he thinks that it is a milk tooth and it will be replaced by a new one. But what happens is that his arch dimension is less, and he ends up having malocclusion. Next is a grown-up female. She is pregnant, and she has bleeding gums and a little bit of periodontal issues during her pregnancy. She thinks she is in a dilemma that should she go to a gynecologist or to a dentist while she is facing such problems. Next case is of a child again who has carious deciduous tooth. His parents decide to leave the situation as it is and let it be, because it will finally be replaced by a permanent tooth. But we know that such cases could lead to conditions like Turner's hypoplasia, and this might be problematic. Moreover, we know that there are parents who think that their kids are they might be a super kid or something like that, because they have a set of natal tooth. So the root cause of all these problems basically is ignorance, lack of proper guidance, and not being able to connect to a professional dental surgeon. So my vision is for a smartphone application which is which will primarily be focusing on primary healthcare. It will guide the patient during emergency and educate the patients what is normal and what needs to be treated. It will give a personalized guidance to the patient based on age, sex, marital status, general health or comorbidities, physiological conditions, and state of the patient, followed with focusing on the patient's chief complaint. It will help the parents and guardians to build positive attitude in the children for dental care, and thus can be used for behavior management in dental clinics. So let us look into the functioning of the app. First, beginning with antenatal counseling, what will happen is the app will ask for details. It will ask for details of the female patient, the name, age, month of pregnancy, and associated abnormalities. It will record all the details, and as time passes, as the female progresses with her pregnancy, the app will notify her accordingly. For postnatal counseling, again, the details of the newborn would be asked, his age, name, weight, height, and associated abnormalities. Again, it will also ask for natal tooth. The app then notifies the parent regarding the maintenance of oral hygiene, cleaning of gum pads, and also how to take care of the natal tooth if they are present. The additional notifications will also be provided by the app for eruption of milk primary teeth, care of primary importance for primary teeth, the type of toothbrush and toothpaste that has to be used, brushing techniques, etc. After 6 years of age, when the child starts going to school, the app notifies regarding shedding of primary teeth, and it will accept data in a Boolean format, like in yes or no format. And if it is a yes, the app will congratulate the child, and if it is a no, it will ask the parent to wait for 6 months or 1 year. And if it is still a no after that time, the app will ask the parent to get a consultation. It will also give trauma guidance. The app will ask the parent about the condition of the tooth, pain, whether it was an avulsion or if it was only a crown root fracture, and then it will guide the parent accordingly how to manage that avulsed tooth. Next, what I want to focus is that there will also be a section about dental content writing, where we would be providing content about toothpaste, toothbrushes, oral hygiene habits, dietary practices. Another is a positive oral attitude, like to be confident about how your teeth is. And we can also use we have a lot of talented second year, third year, fourth year students who can help us with content writing, and we have seen that content writing sector has grown really good in the recent 1.5 to 2 years during COVID. So yeah, to conclude, this is the smartphone application which can potentially help in preventing Google disaster, which I was referring to as cyberchondria. It will also be, provide a patient-friendly kind of guidance. It will also aim in providing comprehensive dental care to the child and to the mother. So thank you.
Thank you, Dr. Shubham. That's quite an interesting idea. I now invite the panelists of the session for discussion. We have with us Dr. Alok Savitani, a senior professor of oral and maxillofacial surgery at Kathmandu Medical College and Hospital. We have with us Sharmila Tapshetty, associate professor of conservative and endodontics at SDM College of Dental Sciences, Dharwad, India, and Dr. Ashok Dangol, associate professor of oral surgery at BP Koirala Institute of Health Sciences, Dharan, Nepal, and Dr. Huda Manan, assistant professor of pediatric dentistry at University Dental College, Dhaka. Thank you so much for joining us. My first question will be to Dr. Ashok. Dr. Ashok, what has been your experience at Nepal with teledentistry?
Good afternoon, ma'am. Thank you for getting me on board on this virtual summit. COVID has taught every one of us new ways of learning and new ways of trying things. So it was related to COVID, what we started with teledentistry. In our hospital, the hospital had provided a hotline number, and as Dr. Alpita mentioned, it was the same. It was through telephone exchange, and it was more of helpful to for trials or sorting out patients or categorizing them based on their priority. Whoever required extraction, we would call them. Similarly, it helped us to determine if the patient had some infection, swelling, so that we could prescribe antibiotics. Similarly, if the patient had pain, we could give some analgesics. But what was lacking was because of the technology and because the internet availability is not that easy for the patients here. The other forms of communication through Viber or WhatsApp was less in our scenario. It was just through the telephone exchange. And yes, basically it was for trials purpose and giving the analgesics or antibiotics as per required. And so we lacked the examination and intervention part from our side. Later, with after the COVID decline, the hospital started its own telemedicine department, and there was a slot for dentistry as well. And the old medicine people used to go there and go for the tele-dentistry there. So it was the same thing again there, just the telephone exchange, less of the video or other visual medium. But what I've asked them as well, what they felt good was they could follow up the patients easily, like the patients with orofacial pain, they had good follow-up and to check how they are doing. It's a good way of communicating. And I have a very limited application of teledentistry as such. I think it's with the telephone exchange itself. That should be from my side now. Thank you.
Thank you, Dr. Ashok. I do agree that internet issues have been a big hurdle for good execution of teledentistry services. I would like to call on Dr. Arpita now to, thank you, Dr. Arpita, for a wonderful presentation of what is being done at your institute. Could you throw some light on what are the challenges you faced with this services? One thing that comes across is definitely the internet issues, technology issues, but are there any other challenges you faced in executing something like this?
What we have felt is that acceptability of telemedicine in the country, or especially in our state. So even though there are telemedicine services, but patients insist on they insist on, traveling for hours and, spending days in travel and staying here in Ranchi and showing the doctor once for 5 minutes. So this requires quite a bit of time to get ingrained in the culture that for any follow-up visits, especially now we are trying to promote this for follow-up. like chronic diseases wherein it is like hypertension, diabetes, or CA, wherein you do not require the patient to come back for every visit, and just the doctor has to write that continue the same medicines. So for that, what we are promoting, our aim for future is that we need to promote telemedicine to that extent that patient has to call first through telemedicine, get consultation, and if the doctor feels that there is need for him or her to come to the college or institute, only then call the patient here. So that acceptability is right now not there. Patient usually feel satisfied only after they have shown themselves to the doctor. But over time, this, we are trying to promote that culture over here. And the other challenge was that the doctors sometimes were not very convinced. They used to think that what we are doing, we are not seeing, we are missing on the examination part, and we may miss something in the diagnosis, and who will be responsible? So that query had come up early in the early days. So we showed the telemedicine guidelines, convinced them, we had some training sessions, and then, people got convinced that this is a thing, government is also pushing it. And so we have to go with the flow, and then slowly now it has become the thing of every day. But patient's acceptability is still an issue.
Yeah, thank you, Dr. Arpita. This brings us to two important things, creating awareness among public, like you point out. One, and second, the training for the doctors themselves, about how not to miss details even when we're doing telemedicine, and developing certain checklists where we don't miss out on certain important findings. I think training and awareness, we come down to these two things where we can have a good execution. Thank you so much. And I want to ask Dr. Sharmila Tapshetty. Our students presented a lot about smartphone applications for healthcare. And there is, this is an era where, we have smartwatches and healthcare applications. Now, do you see any role of these smartphone applications or these technology of this kind in improving oral health of the public? Is there any role of these smartphone applications?
Hello, Dr. Deborah. Yeah, I think to a certain extent there is, but if we go through the number of applications which are available right now on the smartphones, we can probably categorize them into few of them which are product related, like a power toothbrush or something, wherein they give you some indications that, okay, you brushed it for such a long time and you have completed your quota for the day. So these kind of applications probably won't be much used because the people who are actually going in for power toothbrushes already have, I think, sufficient amount of knowledge regarding that. There are other kind of applications wherein the patients have already entered a dentist, gotten their treatment done, and then they are back and they're just getting the intimations regarding when they are supposed to take the appointment or when they are supposed to go ahead with the next set of treatments, or regarding the questionnaire regarding the treatment which they have undergone to check for the efficacy of the treatment. This also, because they've already visited the dentist, I think won't make much of a difference here. But some kind of apps, just as your Dr. Shubham said, I think those kinds would make more difference in the patient's approach. That is, suppose there's a kid who's fallen down and has broken his tooth. The parents are already panicking. They don't know what to do. And in the present COVID situation, they don't have easy access to a dentist. So in such a case, if there is an app which has been developed with the dentist and a software engineer together, probably with all the right data, then probably they'll get to know what is the first aid which can be done at that particular point of time and how the treatment or the prognosis of the particular tooth can be improved. So if there are more and more number of such apps which come into the picture, then I think it will actually play a big role in the present scenario. People won't be actually running to Google and Wikipedia for all the data.
I really like how you put it, Dr. Sharmila, because you're very right on this account that whenever we have a health technology innovation or intervention, I think the health professionals need to be equally involved in developing technology like that. Only then we can make good use of it. Otherwise, it just becomes a marketing gimmick and a sale of a product. So that is a cue for all of us here. If we are actively involved in technological research and we contribute to scientifically approved technology, we can definitely make a difference in public healthcare. Yeah, thank you so much. My next
Thank
question is
you.
to Dr. Huda Manan. You work in the Department of Pediatric Dentistry, and you also heard Dr. Shubham present app about pediatric oral health care. How do you think the public will receive such an app, or do you think such an app? What is your opinion on such an app like this for pediatric care, especially?
Okay, thank you. May I audible to you?
Yes, you're audible.
Okay, thank you, Dr. Deborah, for inviting me as a panelist on this session, and also congratulate to our presenter who have presented earlier, Dr. Arpita, Dr. Arifa, Dr. Shuvangi, and Dr. Shubham Datto. So as a periodontist, I think it's a newer concept for pediatric dentistry. We still not yet started it in our country, but we will do for it. And Dr. Shubham said that these apps will be applicable for a 6-year-old child. As we know, our child is very much smarter nowadays, and they are doing the online classes. So they will be interested to log in on the apps, so they can know about the dental hygiene, oral hygiene, toothbrushing by seeing the videos, and also learning some literature, which will be done by as a cartoon as well. And if it is Android friendly or user friendly, then it will be more effective. And also one thing he mentioned that the pregnant women, they need more information, they need more health education regarding their oral health, also their child's health. He also mentioned about the Turner's hypoplasia, that is the that's come from the infected primary tooth, right? What happened to the permanent teeth, affect the permanent tooth. So this information very much needed in antenatal period, as because if mothers knows, if mothers aware, then their child will be aware. But one thing I want to mention that these apps are friendly or user friendly for our children who get access to internet or who get access to smartphone. But we have to think about our underprivileged child, our disabled child, our physically handicapped child. So we have to work with them so that they can be also aware. At least their caregiver, their parents should aware about this. So thank you, Dr. Shubham, for your wonderful presentation, and also to other presenters who presented today's session. And that's all from my side. Thank you.
Thank you so much, Dr. Huda. You rightly brought about a very important point that we need to reach out to the masses. We can't think of a certain section of a society and develop an app. It needs to be applicable to the masses and to every section of our society. Thank you for bringing that in. And I think Dr. Shubham will be contacting you for his app development. We also have Dr. Megha, who's a associate professor and head of pedodontics in Kathmandu. So Dr. Shubham can definitely get in touch with both of you if he plans to develop this app himself.
Yes, of course.
My next question is to Dr. Alok. So your department handles dental emergencies and emergencies even in the medical hospital, oral and maxillofacial emergencies. How has this pandemic affected emergency care, and do you see a role for teledentistry in emergency care?
Hi, Deborah. Thank you. Of course, see, we've always been doing some form of teledentistry where a colleague sends you a photograph or something for an opinion. Yes, but what this needs to translate into is where patients can send you photographs or whatever problems they have, at least a photograph or a write-up, and where we can follow it up. But in our country, where I see it has a bigger role is especially in oral cancer. Now, we live in a country where people live in the mountains, in the hills, where they come to the city only when the weather is bad. They come like once a year. And if they have a small lesion in the oral cavity, they ignore it. They wait for a year and they show it only when they come to the city. But if we can access them, provide them with some sort of information that, okay, if there is a lesion in the oral cavity, just send a photograph so that it can be at least comprehensively looked at whether it requires immediate care or not. So teledentistry definitely has a role. And I think we just need to, like you guys have all said it needs to go out into the masses that, look, doctors are now available on the phone as well. Thank you.
Yeah. Thank you, sir. I think that's really important. And you brought another important issue to fore, is the oral cancer issue, which is generally, when we talk of teledentistry, we only think of dental pain and dental emergencies. We don't think of the maxillofacial emergencies. And yes, we are still far behind in being able to reach the rural areas. Though there is technology there, though there is smartphone there, the use is limited to only music and videos probably, and not for teledental care. I think awareness really needs to be, we need to create awareness regarding this also. Thank you so much, all the panelists. We now move on to the second part of the session. This session is dedicated to online dental education. Our first speaker is Dr. Sridhar Kannan. He's a professor of orthodontics at Sudha Rastogi College of Dental Sciences and Research, India. He's an excellent teacher, and today he will speak to us on challenges and solutions to virtual dental education. Over to you, sir.
Is my screen visible?
Yes, sir. Yes.
I'll just slideshow. Yeah, so good afternoon, everyone, and I'm so sorry. There's been a slight delay, but I won't take more than the prescribed time. Thank you, APN, and thank you, Dr. Devara, for giving me this opportunity of talking about a topic very close to my heart, because most of the challenges which I'm going to mention have been faced by me during the pandemic. I come from Faridabad. I'm an orthodontist. I have been teaching for the last 21 years. So we all knew when the pandemic began and how, being respiratory, it led to, especially physical isolation and lockdown. And suddenly overnight, we had to change from the physical learning to what you call virtual learning. And that, really hit all of us, especially the dental schools. And why we had to shut down is because of the high exposure to patients from all of us. So, I mean, this was something which hit us hard, and immediately we had to come to an online mode of teaching. Online dental education has been there since 1990, and but it was used just in an auxiliary mode. And all of a sudden we had to, completely shift to an online mode. Of course, there were advantages that it was, regardless of your time, your place, social distance was maintained. However, it required some amount of armamentarium, equipment, facilities, technique sensitive was. We had to switch to certain virtual platforms, certain programs, softwares like Teams, Microsoft Teams. And it was a challenge both for the students as well as the teachers. So if I just need to, summarize as what were the problems faced by us as well as the students. So first and foremost, if I talk about these students, as you can see, all these students are pretty much, bugged with online. I think adaptability was the main issue. How switching from an offline to an online mode, in spite of being a smart generation, using smartphones, being on the net, it was a big challenge for them because they were facing teachers, on a daily basis, and all of a sudden you're in front of a screen. Second was a technical issue, definitely because many of our students were from rural areas where internet was an issue. How computer literate they are is another thing. How much are they aware of the software? Time management was a big challenge, which we got to know from our students because, sitting at home all the time, there were so many other responsibilities given to them. Lack of self-motivation was, I think, a big, big key because, I mean, you're distanced, you're not meeting your timelines, and you just do not motivate yourself enough to study. And of course, distractions, because when you're on a screen, you can be on multiple screens. So that was another issue. What did the teachers as us, what we faced? I think there was an interesting study where they said the main problems faced during online teaching was internet connectivity on the part of the teachers, because, even we also had to have good internet connections, whether we were in college or we were at home. And of course, challenges of technology. Many of us were not well equipped with the technology. So if we broadly categorize the challenges amongst the 12 challenges, I think, student engagement adaptability, a feedback mechanism, the technical issues, and planning a course for the online has been the biggest challenges which we faced. We all know, being dentists, that dental education is basically three things. There is theory, there is laboratory work, that is your preclinical training, and there are your clinics. It is the preclinical training or the laboratory and the clinical training which was hit the hardest, because this is the uniqueness of our specialty. There was an interesting study from which I got this data, and it actually showed that 32%, that is your clinical courses, was unfeasible online. And 26%, that is having high practical, was partially visualizable. So you can almost see that close to 58% of our syllabi was facing a challenge when we came to an online mode. And of course, online devices was another issue which I saw with many of my students who are using cell phones. And we all know, I mean, the screen size of a cell phone and how much concentration can you actually have while you're listening to a class or reading the information provided on a cell phone. And majority was using cell phone rather than laptops. Another interesting study which I found out from as a student feedback was that the feedback given by most of the students related to your practical matter showed that the e-teaching approach did not meet even 45%. So that was another big challenge. Again, we come back to the same thing, that the practical challenge was there. And there was another study which said that 65% thought that the practical courses which they lost, they could not learn again. Of course, social contact with peers, teachers was a big thing. 90% of them felt this way. The other challenge which we saw, that once we went from online to offline, because there were three COVID waves, and in between the colleges started off, it was another challenge because we had some new mandatory health guidelines. We had strict infection control. We told the students you can't go out of the class, you can't do these social activities. There was social distancing. We were constantly reminding them not to share objects and to be more proactive about sterilization, disinfection. So that was another challenge. This was another very interesting thing which showed the comfort level of the students when they were treating. And as you can see that up to 3 and beyond 3 is somewhat comfortable. So most of the students were not even comfortable providing elective treatment or emergency treatment to known or suspected COVID-19. So that was another challenge. Briefly, what could be the solutions? I think what we need to do now is we have to have a good curriculum. We have to have the presentations and the recordings in this thing. We have to engage the students a little more. You must have live session questioning. You must have quizzes. You must give them student tasks, because otherwise it just becomes a one-way communication. You have to constantly evaluate them and assess them so that they are on their toes. And you must have a robust feedback. I think that is the thing which was lacking in online, getting a feedback. These two terms we are going to hear often. I mean, they've started in school, hybrid and blended learning. Hybrid learning is the learning, I mean, where a class is taken simultaneously for both offline and online. So those students who are not able to reach, who are from remote areas or who are having, illness, they can also attend the class at the same time. So it offers a lot of flexibility. It offers a lot of personalized learning. There is active participation, and basically student does not miss out on anything. Then there is something called as blended learning, where your curriculum is divided into offline and online. Some of it is done in an offline mode, where the child comes, you give him certain tasks, maybe some clinical exercise, preclinical, and certain tasks are done online. So this is, I think, the key to the future, that we have to have blended learning, where there is very, very interesting things. Of course, we are short of time, but there is an outside in, inside out, flipped classroom kind of terms, which we are going to hear most often. And the best part about blended learning is the students can work at their own pace and level. So it can be very individualized, it can be very customized. So this is, I think, one thing we can do. The next terms I'm going to use, I mean, these are, of course, high-tech equipments which require a lot of inventory, and maybe they're expensive, but they are the future. Using virtual reality and augmented reality. Virtual reality means where there is some amount of hardware and software which creates a 3D digital reality. And you can get into that and use, through the computer generated sensations and feedbacks, do certain procedures like fillings, restorations, just feel it. So I think that's one thing which could be done. augmented reality basically involves both the real environment and the virtual objects, so that when you're, say, performing a surgery, you have certain virtual templates which are added to that real-time scenarios. This is also a thing of the future. This is happening in a few dental colleges in India, especially to learn dental morphology. And when we use our typhodonts and patient simulators, those physical models, instead of that, we can use digital models, digital handpiece, digital burrs, which will give an instant feedback. So I think this is one thing we should think of. These are the different companies which come. And AI is now everywhere. We are hearing AI. I think AI is the next big thing which is going to happen in dentistry, and which will definitely, is going to improve our education and teaching learning. We don't have to be there physically to learn things. Other strategies, small strategies which I felt, we must have more online meetings amongst these points. I feel we must have feedbacks, we must communicate, be consistent. As a teacher, I think these are certain qualities we must now inculcate a little more. We have to be better communicating, more communicating. We must have a little more empathy. We must, be more understanding, and we have to be, more committed and more involved with the students, I think, because of this online mode. And there are certain best practices. These are certain best practices. I think the important things for us is to have a good online course, to make a good course. We must get feedbacks, and they should be pretty prompt. We must engage the students, because if you're not engaging them in an online mode, then we don't even know what they're doing. These are certain advantages which I had talked about. And if we do a SWOT analysis amongst the strength, weakness, opportunities, and challenge, amongst the strength, we can see definitely flexibility is the strength. Weaknesses, of course, technical difficulties and our learning of the platforms. Opportunity, definitely innovative. The kids talked about so many smart apps. They are the future. They are thinking ahead of time. And challenges is we are all in, developing countries where there is an unequal distribution of ICT and, computer education. So that is one challenge. So I can conclude by saying that, this SARS-CoV has really forced a paradigm shift in the way we are teaching. And we have to adjust as quickly as possible. We have to improve our computer skills as teachers and also insist on students. We must incorporate hybrid learning, blended learning, VR, AR, AI, these terms. We must continue this even if we come in an offline mode, because this has to be part of our curriculum. We should document whatever we have done and share the guidelines, because that's the only way to improve. If we see each other, we have to prepare in advance for a similar crisis. And we must, at the end, remember that this is the new normal. We are now going to live in a society where such things are going to happen. And are we ready? Are we prepared enough? Thank you. I took 1 minute, 30 seconds more. I'm sorry for that.
No, so you're most welcome to have thank you for restricting yourself to that limited time. Thank you so much for this presentation, sir, and it was very enlightening. We were unaware of how innovative we can be in online teaching, actually. We all think of, our mind generally goes towards how to increase personal contact and how to make it more communicative. But to do it online is very difficult, and I've really enjoyed listening to the various methods that you've...
And I think in an online mode, what I have learned is quite a few things from the students itself. Because
Yes.
they're definitely smarter with the smarter devices. So it's still a big learning curve for all of us. It's just the tip of the iceberg. And if we are able to do this, even in a regular scenario, in an offline scenario, just consider an offline scenario where everybody, there is no COVID, there's no wave, but vacations are happening, or there is a large chunk of students who just cannot come, So I think we must involve the online curriculum along with the offline. We must have that more often.
Yes, and I think this is becoming very evident now, and a lot of institutions, at least the schooling institutions, are adopting this pattern, and maybe even professional institutions like ours, professional courses like ours, we may have to consider looking at a hybrid mode. As a
The only
solution.
thing the students will start complaining, oh, I am not well, I cannot attend. They cannot say that anymore. They have to attend.
Yeah,
Thank you. I won't
There
take
is-
any much more of your time.
There's always a loophole when you have some technology come in. Thank you so much, Sridhar sir.
Thank you.
Our next speaker is Dr. Megha Pradhan. She's the Associate Professor and Head of Periodontics and Preventive Dentistry at Kathmandu Medical College and Hospital, Nepal. She will share with us her experience with online teaching, learning, and evaluation. Dr. Megha, over to you.
Hello.
Yes, you're audible, Dr. Megha.
Am I audible? Is my screen visible?
Yes, your screen is visible.
Okay, thank you. Good afternoon and namaste to all the distinguished panelists and enthusiastic participants. It's such an honor and privilege to be sharing our experience on online teaching, learning, and evaluation at such a prestigious platform. The era of pandemic did bring us lots of challenges in terms of our health, safety, and educations. And teaching platform had to take the chance to change from the traditional method of physical teachings to online methods. For the smooth functioning of BDS program in the Kathmandu University implemented a new pedagogical approach that could fit the online teaching and learning. So they formulated an online teaching learning guidelines and they instructed each individual colleges to modify as per their requirements. So the medical education team of Kathmandu Medical College, we worked on it, making a rough layout and getting feedbacks from all the department, and we had compiled it to form the final draft. I'll just go through an overview of how we described our theory classes. So it was decided that in the normal circumstances, we would deal with a face-to-face interaction with the students. But in the emergency situations, in the form of a pandemic or a disaster, we would go through the hybrid technique. In the sense, hybrid technique would be a sort of comprehensive approach which would combine the best of online learning and also the face-to-face physical learning, basically to create an ideal learning experience. We also know that there are always a large number of students. So in terms of online teaching, it was advised to form a breakout session so that the effectiveness of the lecture would be there in a small session. And also some tips of making online class was shared in the guidelines for all the teachers. We also know that it's very important to have an optimal resource for online learning, like the technical resource plays a very vital role. For us, we had Microsoft Team as the official software. And we also advised for the internet with adequate bandwidth. And the most important thing we had was a faculty training modules where faculty were advised and guided on using online teaching learning platforms. And also some guidelines were formulated for the formative and summative assessment. For formative examination, the synchronous platform tools like the video conferencing, whiteboard sharing, Kahoot, Padlet, and quizzes were given. For an asynchronous platform technique, the examples or methods were open book assessments, discussion boards, and research projects. Summative assessment should be done as per the Kathmandu University rule, but as such, the feedback was more emphasized in the guidelines that we should be taking feedbacks from students so that we could move smoothly on our teaching learning platforms. Yes, as with all the teachers had this, I also had fears before my first online class. I really feared that I would be talking alone and I would not know how to portray the pin drop silence I will be hearing from the other side, whether they have understood everything or they have not understood anything. The other queries I had was whether they are attentive in the class or they are just in an offline mode. The other major issues I really feared when I was taking my online classes were the technical difficulties. You all know I just had technical difficulties before my presentation right now, even though I was so prepared. So same fear I had in my I had in my own first online class. So a kind of reality check was there. So how did my first class go? so I had those guidelines from the checklist which I had. So few guidelines I followed from the checklist. It was the camera was always on so that I could see my students. It really made my day because I could see their smiling face. I could get in touch with their personal, I could call their name. So having a camera on was a big boost for me. I randomly called their name, like 10-15 minutes interval. I used to call their name so that I know they are attentive and they are listening. I also gave them permission to raise their hand, the virtual hand especially, so that they can ask lots of questions in between. And they were given the freedom to ask a question in between too. What I did was I always used to allot one person in the group to tell me about my internet issues, like, could you kindly do that, so that the person could message me if I was inaudible, or the person could notify me if something was wrong with the internet issues. The most important thing I did was I emphasized on their participation, which was a very booster for the students. So I'm really sorry. So again, the most important thing of any online teaching learning platform is assessment. So rather going for a summative assessment, we focuses on formative assessment. Like in Zoom really gives us a platform of use of whiteboard. I really benefited from use of whiteboard on explaining about the anatomy of tooth. We have tooth carving lessons, and it was very difficult for me to tell them about all the alignment. So I just could draw them and share with them. So it was a very good learning experience to use of whiteboard. And also to increase your knowledge, we have found that the project work in any form would do very well. If you can see on the left hand side, we have asked the student to form a pamphlet of post extraction instruction where they have done in their native language and also in English. And also on the right side, to assess about etiological factors of dental caries. And to spread awareness, the students were asked to form a project work, and they did Jack's new friend a project work, and they had published in the YouTube. Other formative form of assessment we did was open book examinations and quizzes, which students really liked quizzes a lot, and they gave us a lot of feedbacks, and we could assess them. Otherwise, seminar presentation online, and we used to grade them. Practical experience in dentistry, as Dr. Srija just mentioned, it was a very big challenge for us, particularly in dentistry, because online Viva, we have been taking online Viva or Vivas, we are more comfortable, but having other modes of practical experience was a big challenge for us in Kathmandu Medical College here. And so we started this group discussion where we used to put images of cases in the screen, and the student had to, we just gave them a topic, like maybe an early childhood caries. I gave them a topic that tomorrow we'll be discussing on early childhood caries. So when they came on the next class, I had presented them on the pictures of early childhood caries, and we had to discuss about the stages, the management. So I think the group discussion also played a vital part on online teaching. Another challenge was identifying them spotters. We have spotters in a form of assessment also. So we had clicked pictures of most of the instruments which are needed and labeled them and the characteristic features so that they could learn from them, and we could assess them later on this aspect also. The bigger challenge we had was summative evaluation. It was the biggest challenge for us because we had to conduct sessional and pre-university via Microsoft Teams, though we had received prior training of software for invigilators, and also the students were quite aware of how the Microsoft Teams were used. The format was, the MCQ was provided in Google Forms, and the SCQ was provided as a question in their chat box, where they had to fill in different section B and section C. They had to fill in different section and send to us by email. There were lots of instruction given to the students. We made sure that they had the individual email ID, they had the username and password, they had logged in properly, they had gone to the respective group, and the question used to come directly on the allocated time, and they had to submit as per the rules. Other instruction they were given, I'm sorry, other instruction, because to this effort, this was kind of precaution which was taken to prevent a bit of discipline or to prevent cheating in terms of the sessional exams. They had to give two devices, one with continuous video where their face and the paper would be shown, and another device for clicking pictures, photos, and sending emails. We had advised them not to use video, and video should not have been interrupted during the whole examination. So there were a lot of rules given as an instruction, and we conducted the examination of sessional and pre-university. It was a big challenge for us. I'll be discussing in a while. First, challenges of online teaching, which we faculties at KMCTH we faced was we realized the biggest challenge was to establish a fully functional distance learning platform, a curriculum where we could get a flow of what we were and how we are going to teach. The faculties were not so trained or accustomed to online mode of teaching, though we got a lot of training. Some faculties had a lot of problem in using computers and those related gadgets. Even though a lot of effort has been taken from the college administration, there were lots of problems with hardware and connectivity for hosting online learning software platforms, which was found to be very weak at times. So this was the major challenges of online teaching we faced at KMCTH. And evaluation was a really big challenge for us because the students, they did very well in the theory exams, but we had a chance to take the practical exam of the student, and we really doubted when they could not answer a simple question. So basically, the challenges for evaluation rested upon the trust issues. If you can see in this picture is a picture of one of the examination conducted, though we have advised, we have instructed the students not to keep to show them their face and the paper. It was hardly manageable. Even though one faculty was there for a few group of students, we literally had to give instruction every time. They were complaining of technical issues. They were complaining of a lot of problems. So it was, I think they were also disturbed with the fact that we were literally unmuting ourselves and talking to them, like, focus here, can you show us a face, or can you show the paper? So I think they were also getting disturbed, and we were also having a lot of technical hassles from our side too. The other challenges we felt was lack of course design. As we talked about, the curriculum or the modification should have been done before the content, and we were giving questions of the physical style among the online, which was quite difficult. So I felt that the MCQs could have been modified in a way that they could have been reshuffled, and even the choices could have been reshuffled. Or other method would be the student would not get any, the technical specification could be such that the student could not navigate back to the MCQs, so that it will quite be fair on their part. So these were some challenges we were facing, and basically, it was our first attempt on doing an online based evaluation, and the most important issues was trust issues. I'm sorry. So because of limited time, I had to cut short of a lot of things, but few things I would like to mention as a take-home message. We all know that online teaching learning is evolving, and we also know that dentistry is a bigger challenge for us because it is based on competency-based education. We are here to test about the theoretical, apart from theoretical knowledge, we had to test on the practical skills of the students, and also the patient attitude, how they are handling the patients, and how they can treat a patient independently also poses a very big challenges. And among all the challenges we faced as a teacher, or it was the most important challenge was student motivation. Will the student get motivated like in the physical classes on online basis was a bigger challenge. So the hybrid technique or the blended learning technique or the flipped classes, whatever method we can opt would be a good option for online teaching, learning, and sharing. And we also realize that evaluation modalities, they need to be reassessed at times and evaluated at times, so that it could follow the same online teaching learning protocol, whatever has been done. So maybe curriculum could be revised in a sense from the university itself, so that we could have this newer technology on our side. I would like to thank the organizing team of APAN and TEMTAG, Dr. Deborah and Dr. Alok, for all your support, and last but not the least, for all the participants who have been listening patiently to me. Thank you so much.
Thank you so much, Dr. Megha. Thank you. It was really a wonderful presentation, and we've got to know how you've handled the challenging scenario in these times with the methods you used. Thank you so much. It's really appropriate now to hear from our students what expectations they have from teachers in online classrooms and offline classrooms. So our next presenter is Dr. Apurv Rana. He will present to us the student perspective on online teaching with the innovations that they have in mind for teachers. Dr. Apurv, over to you.
Learning and innovation goes hand in hand. The only way to discover the limits of possible is to go beyond them into impossible. A very delightful evening to everyone. This is Dr. Apurv Rana from Faculty of Dentistry, Jamia Millia Islamia, presenting on the topic Innovative Methods of Teaching in Dental Education. So first, before starting, we need to know why there's need. So healthcare profession is continuously changing day by day. Hence, educational institutes are thus seeking to innovate, improve, and making the teaching more effective. The new teaching methods thus promote skill-based as well as self-directed learning and knowledge. This focuses on better learning, improve self-efficiency, self-motivation, encourage learners to formulate their own learning objectives. And this also enhances the team and collaborative learning, which ultimately improves the student's self-confidence. So first, this is problem-based learning. So PBL, the problem-based learning, has been described as a method where problem aids as a catalyst for learning. So here, the PBL curriculum is that the problem always comes the first. So what did we do? Traditional learning, students are given the information, then they are asked to memorize it, and then it is assigned as a problem. So what the PBL do, it is assigned as a problem first, then student must identify the needed information, and then student learns the information and apply it to solve the problem. So what are the benefits? These are the benefits, like it's natural, it's motivational, learned applied knowledge, and encourage preparation and homework. It is also a team base, which ultimately gives a lifelong learner. Second is flipped classroom. So flipped classroom, in this thing, classroom will be all flipped. That is, lectures that will be used will be taken at home, and at home the lectures will be taken. Similarly, for the homework activities that was taken as in traditional approaches, now the classroom activities will be more interactive for the students. So here, the interactive learning experience are the methods of assigning the learners didactic materials to be learned prior class, along with utilizing classroom hours for interactive and active learning. So the PPT presentations or the videos of the lectures are provided to the students 15 days prior so that they can extrapolate the topic. So here, as the instructor prepares the material to be delivered in the class, and the student listen to the lectures and other guided instructions in the class and take the notes. And in flipped classroom, the instructor records and shares the lecture outside the class, and the students watch or listen to lectures before coming to the class. So in the flipped classroom, in the class, the student gets the creating, evaluating, and analyzing things, and applying, understanding, and remembering things. It is done outside of the class. Third is micro teaching. In micro teaching, it is a mini teaching confrontation that is aimed to create recent techniques and improvise the old one. So it converts cumbersome chapters into learnable entities, which ultimately helps in the leading coordinators. Micro teaching during practical and clinical postings. Here, each mentor has given 3 to 4 students under him or her. It helps to foster a student-teacher bond. So it has been divided into 5 stages. The first stages comes with the briefing phase, where the teacher briefs the thing that is going to happen with the students. And the stage 2 comes with the preparation phase, where the teacher prepares the process, the slides, the presentation that will be given during the micro teaching lectures. Then in stage 3, it is the teaching phase, where the teacher presents his lecture to the students. Then 4th is the feedback phase, and the 5th is the replanning phase. Then 5th is the case-based learning. Case-based learning encourages the active learning by employing the clinical case scenarios in which the mirror real life experiences that students will encounter during the clinical stage of their dental education. So here the cases are targeted as problems which equip the students with patient details, like case history, like patient's past medical history, etc. and laboratory findings also. It is an active learning model which empowers the to generate knowledge rather than only receiving and enhancing their skills for sharing with the other people in a group. It strengthens the logic, collaborative, as well as the communication skills in the students. Then 6th is the digitalizing the histopathology thing. As we all know that histopathology teaching in medical and dental education has traditionally relied on the light microscope in lab settings. With increasing student number, limited flexibility of the tools for learning outside the lab, and most recently the COVID-19 pandemic, search for alternative procedures has been taken place. So digitalizing the histopathology classes for students, here the creation of interactive library of the slide mounted tissue specimen accessible through the institutional virtual learning environment. So the images from the microscope on the big screen are explained to the students, and an analysis of the different views increases the analytical skills of the students to diagnose the case-based histopathology. So here, first the patient data is collected, then the preparation of the digital slides is done, then image storage is done, then editing of the captured image, and the viewing and sharing the images through the classrooms. Then 7 is evidence-based learning and virtual stimulators. Evidence-based learning includes all the use of the current scientific evidence for decision-making in clinical setting. It helps in effective decision-making skills, form the basis of the research and its application in practice. Where the virtual stimulator is stimulation combined with technology is done in dentistry. So here, virtual reality-based stimulation like the IGI, image-guided implantology, the VRDTS, virtual reality dental training system, and IDSS like lower dental surgical stimulator. These methods improve fine motor skills and hand-eye coordination of students in preclinical settings. So we conclude with this, that teaching in all fields has progressed a lot from conventional lecture-based system. So conventional lecture-based system continues to be the main method in the many institutes, while others have adopted innovative methods for the benefit of the student as well as for the teachers. So, but it also faces some challenges, like the institute should have sufficient infrastructure, appropriate training should be given to all the faculty as well as to the students, and efforts should be also taken. With this, constant monitoring and feedback should also be done. Thank you.
Thank you, Dr. Apu. Thank you for presenting some innovations that you think will be useful for your own education. Thank you. We now move on to the last presenter of the day, Dr. Priyanshu Srivastava. And he will be presenting to us a new teaching method implemented in the pathology department. Dr. Priyanshu.
Yeah, hello all. I am Priyanshu from Faculty of Dentistry, Jamia Millia Islamia. I'm just sharing my screen. Just 1 second. Dr. Shubham, I'm unable to share my screen. Can you please do that for me?
Yeah, just a second.
Yeah. So hello all. Today I'm going to present an approach towards clinical learning in an online mode. So in the COVID pandemic, as we all experienced, the online teaching came with its challenges. It took a adaptation time, and the student participation was quite less. So we use this real life case-based approach. As Dr. Apoorv discussed, this case-based learning was a little extended, and we used it in a real life scenario. So in general pathology, can you go to the fourth slide? Yeah. So in general pathology, what we use is hypothetical case learning, in which the case studies in the form, an ideal case is given to the students in the form of which the clinical history and the lab reports and other related information is given to the student, and the student is required to make a diagnosis based on those given information. And other questions are asked, and according to that, the student has to answer. But that becomes a little unidirectional, and the participation and the engagement of student is not quite very good. So we use this real life case-based learning, in which the student had to identify a previously diagnosed case within their own family or friend circle. Particularly, we use non-communicable chronic diseases such as diabetes and hypertension in this case-based learning, so that the risk of transmission is less. And other anyhow, however, the flexibility was given to the student to choose their own case. So the students reviewed the previous medical records of the cases. They took a detailed case history from them, and then they presented the case history in the form of assignment in a Google Classroom. So as per the materials and methods, this real life case-based assignment was given to the students of second BDS academic year for diabetes and hypertension, or diabetes plus hypertension case. They took the case history from their family and friends themselves. And can you please go to the next slide, sir? Yeah, so a set of questions were given to the students to guide them to take a case history, since they are not very experienced at a undergraduate level in second year to take a very detailed case history. Some questions were given, such as their risk factors and clinical presentation and everything. So next, after the case history, the students were required to make an assignment explaining the questions and their assessment and analysis on the subject. The assignment was then presented on Google Meet by the students, and that was followed by a group discussion, including the faculty and other student members, so that a very good, healthy discussion could take place. After the whole process, the students' feedback was also obtained about the assignment. So as per the results, so the students, can go to the next slide? Yeah, so the students appreciated the hypothetical case, the real life case more better than the hypothetical case-based learning. And the usefulness, next slide, please. And the usefulness of real life case-based learning, they found the real life case-based learning helpful in understanding the disease process better, that received the largest response. And then the interaction with the real patient, and early exposure to the clinical things. The students in second BDS are generally exposed to the clinical aspect in the third year itself. But in this, they got to talk to the patient and understand the psychology of the patient in the second year itself. So real life case-based learning, can you go to the next slide? Yeah. So this real life case-based learning gave an early patient exposure to the students. Students understood the socio-cultural practices and behavior of the patients with non-communicable diseases, that is diabetes and hypertension. They understood the challenges faced by the patients better, because they were their own family members and friend circle. So they could talk to them and feel empathetic for them. So the students' active participation and critical thinking was very engaged, and they build rapport with the patients, and it also helped them with their communication skills itself. So as a future innovation, the introduction of real-life case-based approach in other preclinical subjects such as pharmacology and microbiology in secondary itself, and clinical subjects like in the online curriculum when the teaching mode is online, this real-life case-based approach can be used in the medicine and surgery department itself, so that the students do not lose on the clinical aspects. So in conclusion, this real-time case-based approach utilize the online resources and engage the students to learn actively and build their critical thinking. So thank you for listening. Have a great day.
Thank you so much, Dr. Priyanshu. Thank you for your insight on what was done in your college. I now invite the panelists back in action for a discussion on this section. I would like to ask Dr. Sharmila, start with Dr. Sharmila. Dentistry is partly a skill-based profession. I shouldn't say partly, it is definitely skill-based profession. And I would like to know, how do you think we can address teaching clinical skills in online classes? Is it even possible? Dr. Sharmila, you're muted.
Hello. Yeah, am I audible now?
Yes, you're audible now.
Yeah. So yeah, Dr. Deborah, I feel yes, dentistry is definitely based both on your sound knowledge and your clinical practice. And to most of this thing, to a higher extent, the clinical skills actually matter a lot, which cannot be taught completely by your online method. But to a certain extent, if we try, then okay, so some parts of the online clinical skills can be taught. Like if you're giving your mattress suture or some kind of suturing techniques, the students can be asked to make videos of the suturing, what they have been taught, to do it on some sponge or some kind of cloth, and post the videos along with the procedure how they're doing, so that the person who's teaching can also understand whether they've understood it and how, whether the procedure they're doing it is right or not. So many things which do not actually require all the machineries and the compressors and all the things possible. Yes, we can try to include dividing the students into smaller groups and trying to do. But if it comes down to using eroters and micromotors, that I don't think is possible right now. Probably in due course of time, if the same online teaching keeps on continuing, just like how right now if we go to a driving school, the first thing they do is they put us in simulators so that we don't go and hit somebody. So I think probably we'll have to start getting into some kind of simulated form, which can be applicable in a smaller extent, like the video games which people keep playing now, so that they'll get to a certain extent an idea of how it is going to be. But it can never replace what has to be done clinically, I feel.
I would agree with you. I would definitely agree with you. I think the skills which do not require personal contact or technology, our instruments, is still possible to be taught, but we cannot replace face-to-face classes and face-to-face personal teaching, especially with skills. Thank you, Dr. Sharmila. Dr. Alok, if you're here, Dr. Alok.
I'm here.
Yes. My next question is to you. We've heard so much about flipped classrooms, and it is in progress in non-professional courses. Do you think a flipped classroom has a role in a profession like dentistry?
Definitely, like as has been discussed, and even Dr. Megha mentioned, that we are a competency-based education. For us, the skill matters probably more than just the theory, a tad more than the theory. So if flipped classrooms are used, that gives us more time for training, learning skills in the during the college or clinical hours can be increased. I mean, taking a couple of hours for 2 lectures, if that time was dedicated for skill learning, that would be much more useful for students. Yes, the drawback is the faculty has to work more. They also have to work after clinical hours to prepare the classes. But yes, flipped classroom would be great for dentistry, especially now to compensate for the time that the students have lost during the COVID time when we were closed. I think it should be done at least for a couple of years to at least compensate them and give them more exposure in the clinics.
Yes, I think I would agree with you also here, especially because now students are exposed to a lot of literature already, not just literature, resources. So they come to classrooms already have gone through previous PPT presentations of previous faculties, and there's so many e-learning resources that are already available. So the interested students have gone through them already. So instead of wasting time on repeating the same theory content, it would do us a great deal better if we focused on implications of that content, implications of the theory, and using that theory, and the skill development, of course. Thank you so much, Dr. Alok. My next question is to Dr. Sridhar. Thank you so much for that wonderful lecture. It really was an eye-opening lecture. But I would like to ask you what challenges you faced in assessing a student's performance, or how have you done online assessment in dentistry, and what challenges have you faced there?
That question was for me. Hello.
Can you hear me, sir?
Yeah. Okay. The challenges, I mean, I think similar to what Dr. Megha's presentation was. I mean, we had, 2 devices for every student, and we had a proctoring device for the mentors as well as, invigilators, online invigilators. It was a big challenge, believe me. And especially for, I mean, the universities also didn't realize that there are children and students who are having siblings who are also students. So you can't have, a family cannot have 4 or 5 devices. So in spite of the fact that we are aware that, students might be, cheating or using unfair means, we have to give some amount of leeway and maybe explain to them that, look, it's for your benefit not to cheat. And secondly, I think what all these big universities, including the one I used to work with initially, they were very proud that we had 100% attendance, which is, I think, something, which soon all of us realized that they just used to come for they mark their presence, and they used to mute themselves. So that was also, I think, a big problem, which initially we were all very proud of, that we had 90% attendance, 95% attendance. But as soon as you ask the students, my mic is not working, my net is dropped, my internet is weak, until then they're quiet. So there are definitely challenges, but I think if we have a feedback mechanism, if we are constantly giving them tasks to do, if they come back we give them small presentations to perform, we give them small homework to do, definitely, it will be more involving. But like I said, it's a learning curve for all of us. I think we've still done a relatively good job of keeping all of us safe, of ensuring whatever form of education we can do, we do that. And I think many students have come out really strong out of this pandemic, because, it has hit them mentally also, and it has hit them on an emotional level. So as a teacher, I think emotionally, mentally, I mean, being much older and much more mature than them, we have to also think on those aspects. It's not just your curriculum and everything, and curriculum needs to change. If you ask me, there has to be a big radical change in our dental curriculum. We are still going by 50-year-old, 60-year-old, 40-year-old procedures, which are non-existent now. We definitely need to change. There has to be more hands-on. It has to be more, problem-based learning. It just has to be problem-based learning. We are not giving clinical scenarios on a regular basis for them to understand, to learn. So I think everything is theory, and the 7 points, the 10 points. I think we have to come out of that scenario. Real life cases, real life situations have to be given.
Yes, sir. Thank you. Thank you so much for bringing that in this forum. Something that I think a lot of us have talked in our small groups in our discussions, but I've never brought it out in a forum like this. Thank you so much. Definitely our students have taught us how to handle online presence innovatively. They really taught us how to handle an online presence. So I want to ask Dr. Megha, what are the disadvantages of virtual education like this? What are the disadvantages? We've seen so many students, they are there for attendance, and they really don't shirk away from telling you that ma'am, they don't. So how do we handle something like this? How do we impart education to a group of people who are only half interested in being educated? Sometimes, is there anything we can do there?
Thank you, Dr. Deborah, for a very interesting question, actually. So a really practical question where students normally they come for attendance, and it was one of my fears when they just mute themselves and then they sit. So a few things I realized, these are the disadvantages of an online teaching learning, where it is very difficult. It is more difficult than the physical face-to-face learning. In online, is very difficult to get their attentions. But a few modalities we can apply is that either we give them like before, prior to the class, we can give them some quizzes. Okay, and then later on we can assess them. So when they know that there is something like this, or some questions are going to come their way at the end of the class, they are supposed to be attentive. So it's a bit more work from our side, but we can do that. As I mentioned before, for attendance, what do I do is I keep the the least interested person, if I can find out in the previous class, I keep as a head, or the person to tell me the attendance for that day. Something like that I try, the hit and trial methods, which I do. I tell them, could you see my internet issues to one person? So one person, I made them a moderator, like if something happens, we can discuss. Or one person, I will just randomly call the name and tell them, after that you need to summarize. Something like that I do, and I find my class attentive as such. I don't know, they must be sleeping too, but now they have stopped putting the camera on. So that's a bigger disadvantage now, because they feel their privacy, so they have some privacy, so I just don't force them on camera, but I do that. So what happens is, randomly we know that we cannot normally take a class of like 30. After 30 minutes, normally in physical class also, no students will be listening, everything is going over their head. So basically I have this breaking down thing, which we can apply in online too, where 10 to 15 minutes we can just call their name randomly, or ask them question, or summarize. So I think if we can do that, we can really get their attention. And giving project works and online, and I really liked about the idea about the fifth classes, because it will not be applicable in the sim, but when you give them projects, like maybe on the next class you can say a few words on, Dr. Shida was saying we could do that. So a few words on this one. So maybe an assignment sort of thing, where they had to present for 5 minutes. I have done that, and it works really well. And I made sure that you can't be absent on that day of your presentation, because you need to make 2 presentations later on. So so I think we can work it out. It's very difficult for our teacher also, because we have to face the clinical scenario, and we have to be apt as an educator also, and we have to get the students' attention. Is too much on us, and sometimes we don't want changes. We want to go on the stereo method. So I think bigger challenge is for us also to change. So I think that's what I feel.
Very right said, and thank you so much for all the inputs you've given of how you managed the online difficulties. And thank you so much, Dr. Megha. My next question is to Dr. Ashok. Dr. Ashok, how do you think we can make online classrooms more interactive or personal? Now, yes, giving curriculum-based projects, like Dr. Megha said, that's really very good, but there is this disconnect, that you're still facing a screen when you're presenting, and the students are also looking at the screen. Now, how do you think we can make it more interactive or more personal for the student?
I think we need to keep the classes short and simple, because it's very difficult getting them engaged, because there are lots of distractions when they're in an online class. So I think to prevent those distractions, we need to keep them engaged, as what Dr. Megha had mentioned. We can have these. Zoom is very versatile. We can have these whiteboard. Similarly, we can ask them to use these annotate buttons, and then we can even have some breakout sessions where they can divide in groups and come back. Might be difficult, but yes, we can always try. And as what Sridhar sir had mentioned, if we can involve them into some gamification, because gaming is it's very upcoming these days. And even if these online classes have some gaming advantages within the class itself, with these AR and VR stuffs, if they are involved in these online classes, and I think the physical classes would be obsolete itself. So I think engagement, we can engage the students by breakout sessions and gaming with some quizzes, as what Dr. Megha had mentioned. I think we need to engage them, then give some assignments, and get some feedback for ourselves as well. Thank you, ma'am.
Yeah, thank you. Thank you, Dr. Ashok. I think you summarized the whole entire session really well. My last question is to Dr. Huda. What has been the online virtual education experience in Bangladesh at your university? What has been it? How has that been?
Okay, thank you, Dr. Deborah, for allowing me to discuss about the crucial part that is the Bangladesh experience regarding the online education. And I also feel privileged that APAN has used our Bangladeshi heritage on their background. And if I say during this pandemic situation, online education or distance learning, it's a new prospects of opportunity for the learners and also for the students. But it also creates some form of challenges or difficulties for us. So if I say Bangladesh experience, I could explain it to 4 categories. That is number 1, the policy level. Number 2 is the organizational level. And number 3 is the community level. And fourthly, at individual level. So at policy level, Bangladesh government has taken a prompt decision to start the online education along with coordination with Ministry of Education and also DGME, Director General of Medical Education, and DGHS. And also they have broadcasted the offline classes through national television and through national radio station with other related radio station for those students who are not able to get access to internet facilities. And you will be happy to hear that Bangladeshi people, around 92% of people using the mobile data to get access to internet. So overall online education was not for so much difficulty. Bangladesh has taken it taken these challenges very well. And also, if I say the organizational level, the private medical and dental institutes have started their online classes a bit earlier than the public institute. And if I say, I am really glad to inform you that our chairman, Dr. Wahiduzzaman, under his leadership, and along with our principal, we have started the online dental classes after a few weeks of lockdown. The lockdown was on 20th March, and we have started our online dental education class on mid of April. So only little time was gone for students. And if I say the community participation earlier, their response was very little, or they were a bit confused about the online education system. But later on, they adapted and they accepted very well. And if I say at individual level, our faculty members, they are not well trained, but they tried hard to get attached with the online classes. They use so many different apps like Zoom platform, mostly they have used, and also uses Facebook Live, WhatsApp media. And also they shared their PowerPoint presentation, videos, also shared their audio video content for lecture presentations. And if I say about the students, they were almost all of are responsive, as it was newer to them, and they can start to join the classes and also interact with their colleagues and batchmates also. So they enjoyed the time. But what we have faced to continue the inclusive online education, that we have faced so many challenges that already Dr. Sridhar and Dr. Megha explained it very well. So same things we have faced, that is the lack of uninterrupted network and low network speed sometimes, especially the peripheral area and the rural area of Bangladesh, and also lack of infrastructure like laptop, then the desktop webcam, as due to shutdown, there is shutdown of the markets also. So to get the gadgets, it was difficult for the students to manage it. And another one is the that is our faculty member faced, that home noise. As you know, we are working from home. Students were joining from home, so home noise was there, and also we missed the face-to-face communication. That was only the one-way communication. Student entered the class and they muted the video and audio, and we don't know whether they are present or not. They are just attending, so they become a passive learner. And another important thing is that dentistry is a skill-based and practical-based learning. So it was more difficult for us to provide the clinical demonstration through online. Live presentation was absent totally. So, and another one is that due to lockdown, there is also economic shutdown, as you know, all over the world, and the financial incapability for the family to bear the expenses, such as to purchasing the gadgets and also some other technical tools, internet packages. That was also a difficulty, and that was also challenges for each level. Moreover, I felt that we need to go for blended education system, and also we need to improve and also try to update ourselves, and only transformation into the course curriculum or the class teaching method is not bring the changes, but also the policy paradigm shift and also the good community participation also needed to provide an effective online education. And I think through online education and changing our education system also, we can make our students more powerful, more creative, more innovative, and they can represent themselves internationally through a virtual platform. So I think it should be done. Then we can move forward with our students, with our new generation. And thank you all.
Thank you so much, Dr. Huda. You made my conclusion very easy. You sort of concluded for me, and thank you so much. We are running short of time, so I will just reinforce what Dr. Huda has mentioned, that there is a great scope for teledentistry for patient care as well as for online education. These are all parts of our teledentistry broader, the broad term that we are using. So creating awareness is one that we need to focus on, and updating ourselves and training others who are in this field of education is something that each of us has to work on. So I think our take-home message will be awareness and training, awareness and training, awareness and training. I would take this opportunity to thank each and every one of you for your wholehearted contribution and participation. Thank you especially to the speakers who've taken time out of their regular work and clinical schedule and home time and have prepared and researched well and presented their content today. Thank you so much. Thank the panelists for taking time out and discussing over the things that have been presented. I hope we've all learned things and have had enough discussion on what we've been talking about. We've learned enough to go back and implement some of these things. I thank APAN for this opportunity, for selecting our session for this on this platform. I thank TEMDEC for their unhindered support at any time of the day in getting this to happen. I thank each one of you wholeheartedly. Thank you so much. We've come to the end of the session. Is there anything anybody wants to say? You please go ahead.
Thank you.
Thank you.
Dr. Deborah, how about a group shot? So if everyone can turn on their camera.
Yes, that'll be excellent. Please. Dr. Sridhar, are you there? We don't want to miss your photograph.
Okay, I'll take
I'm
the
in my clinic,
screenshot.
actually.
Yes.
Okay.
Clinic. Yeah. Thank you.
Thank you.
Thank you so much. Thank you.
Thank you.
Yeah, I will send the screenshot to you, Dr. Deborah.
Yes, and I'll forward it to everyone. Thank you so much, everyone. Thank you for your time. We've exceeded time limit. I'll need to cut the short. I'll get back to each one of you personally. And thank you so much. Thank you.
Thank you. Bye-bye.
Thank you, everyone.
Great meeting
Bye.
you.
Thank you.
Thanks.